Computer audio?
No, phone
No,
call.
phone call.
We hear you.
We're gonna
I
call
think
in.
Go ahead, there's the phone.
we hear you now, I think. Mr. Secretary, well, it is muted. Let's make sure that we have the acting secretary.
We are live.
We hear you. Make sure that they're joining us here any moment. Sorry, we are a work-friendly environment here with the Vaccination Oversight Workgroup. Despite virtual backgrounds, children are always welcome. All right, hello there, Mr. Acting Secretary. Can we hear you? It looks like, there it is. Okay, great, we can hear you. Wonderful. All right, well, let's go ahead and jump in. We are waiting for a couple other workgroup members to join with the updated link. I want to thank everyone for being here today and appreciate the Acting Secretary's presence here this afternoon. Look, I think start with the good news. It looks like a lot more doses went into arms in Maryland this week, which is really positive. And I'll sort of let Mike and the Secretary go through some of that. What I think we're really hoping to get a sense on, and what we heard a lot since the last meeting, was really on that predictability of the allocations and really getting a better sense of that predictability. So I don't want to take up time. We are going to have a presentation from Department of Legislative Services. We'll have 5 minutes or so for the acting secretary, and then we're going to go into questions, and we'll try to reserve 5 minutes for each member of the work group to make sure that they have time for questions. But we're going to be, kind of keeping to a tight schedule. All right, let's go ahead, and Mike, if you can get us started, and if we can put the presentation up for this last week's dosage information.
Will do. Can you see it?
We can.
Good. Then I'll get started, and let me see if I can make it larger for you guys. There we go. So just as a bit of background really quickly, this is the change in the kind of status of coronavirus in Maryland since the middle of December when vaccinations first became available. The number of positive cases, new cases, is down 31%. The percent positive rate is down 23%, and the number of tests being done per day is down 10%. Moving on, this is the number of vaccines that have been done since we began vaccinating. And as you can see on the right, the most recent week, there was growth in the number of vaccines that we administered. And those orange parts of the bar are second doses. So they went to people who had already had a first dose. And you can see that there is growth in the number of second doses that are going out, especially. This one shows the total number of doses that have been administered. That means it's been put in somebody's arm, whether it's a first dose or second dose, compared to the blue area, which is the number of doses we have in our possession in Maryland, but haven't been administered yet. You can see that on maybe the 26th of January, there was another delivery of doses made available in Maryland. This chart shows all of the states and kind of compares Maryland to other states as far as the number of doses we've given per our population, and then the number of doses that we have available that we've used. So the higher you are, like Alaska, means the more people have received a vaccination, whether it's a first or second. And then the further to the right you are, the more that state has used the doses that have been made available to them. So you can see where Maryland ranks compared to other states on that chart. Moving on, this is the ratio of first doses to second doses since a couple weeks ago. As you can see early on, as expected, most people were getting first doses because it hadn't had the 3 or 4 weeks yet to give a second dose to somebody, as the kind of technology of the vaccine requires. In the most recent days, we're doing about 2 first doses for every second dose that we administer. So we'll continue to watch that ratio of doses. This is the change in the number of doses administered first and second, and compares Maryland to the other states. So the higher you are, the more increase in second doses given, and the further to the right you are, the more increase in first doses you've given. I don't want to make this sound too complicated. Maryland is one of the top states as far as growth in the number of second doses given, and is probably somewhere around the middle of the pack, or maybe a little bit better in the in the increase in the number of first doses given. However, I will show on this next one, this shows since the beginning of time the number of people who have received a first dose and a second dose. So again, the higher you are, the more second doses have been given. The further to the right you are, the more first doses you've given, and you can see where Maryland is when we compare to other states. I would say generally you want to be as high and to the right as you can be. Then we took a look at sort of some equity issues this week, and this does not show overall rates of vaccination, it shows growth. So this week compared to the previous week. And most of the growth in vaccination for white Marylanders has exceeded growth for people of other races. We looked at this for ethnicity as well. You can see that white, non-Hispanic, or Latinos has grown more than Hispanic and Latinos. This looks at the growth by age, and as expected, most of that has come from seniors, people over 70 years old, and people 80 and over. So 400% growth in those categories, as I think our strategy is and as people would expect. Then I want to caution on this one, as with the ones preceding it, this is growth by county, but over the last week. So if you see like Charles County has had a tremendous amount of growth, that doesn't mean Charles County has done more vaccinations than any of the rest of these counties. It just means that compared to last week, they've shown the most improvement. I think the most improvement. I've got my video in the way of all of the bars on this. And finally, we showed this last week. I'll continue to show it. We vaccinate a ton fewer people on Saturdays and Sundays as we do during weekdays. And I just want to continue to bring that to the work group's attention. That is all I had prepared to share. Thank you, Mr. President.
Thank you, Mike. Let's hand it over. We're right on time to Acting Secretary Schrader. And we have to unmute the Acting Secretary. Might be on a different device. It looks like it is a phone mute.
Unmute.
Okay, can you hear me now? Great, okay. So we have a couple of slides to share that add to the information that Mr. Powell showed. We'll start with an equity chart.
You have to unshare.
Oh, okay, go ahead. So we'll get this slide up. But we wanted to share, there was questions last week about equity and the vaccines that are being provided to counties in an equitable fashion. So we'll want to show you what we've been using. Last week we pushed a lot of data at you, so we held this one back. Given some of the questions we've gotten, we wanted to show this. But we're using a whole of a county approach. And early on, working with the counties, we agreed to a floor of 300 doses for small counties based on early consensus with the local health officers. So are we having a little difficulty with that slide? Okay, let me try mine. Why don't you try yours, Webster? Stand by. Apologize for that technical difficulty. Okay. Going. I'm going to keep going. While they're getting the slides, let me keep going so we, in the interest of time. A lot has happened in the last couple of weeks. I'll come back to the equity chart. We've added another channel. You probably heard this in the governor's press conference last week. We're adding mass vac sites. There's going to be initially 6 of them. The first 2 are planned for Six Flags and Bowie, and the other will be at the Convention Center at Baltimore. Those will start on February 5th. And the one in the Convention Center in Baltimore will continue on after we move to the M&T Bank Stadium, which will be closer to the middle of the month. And there'll be a hotline that people can call. We're getting ready imminently to roll that out. And we will, but in addition, we're going to continue to encourage Marylanders to use the 211 press 2 for information regarding non-state run vaccination sites. And we also have covidvax.maryland.gov, which is a locator site, but we want to make sure we have phone capability for seniors who don't use computers. Now, let me pivot back to this chart. What you can see here is each of the counties, their population, the percent of the total population, and the percent of the dose vax share that they've gotten. If you go down that list, you can see it's a very close and tightly wound around the population. It's off in a couple places, but pretty much on track. And then we've got another chart which shows the number of doses distributed or allocated last week, 70,148, and the doses per thousand, the average is about 12. So we're measuring this. The one thing, and I mentioned this earlier, for the smaller counties, because we've created these floors, so for example, Kent County, they had 400 doses. Their floor for the local health department was 300. So that puts them at 21. So very small doses, numbers of doses in the very small counties drive that average up. But as you can see, the doses per thousand on average is 12, and it's for most counties it's somewhere between 10 and 13, except for those 4 or 5 small counties. And we're going to continue measuring this every week, and this will be how we ensure that we're getting every county an equitable share of the doses. If I can go to the next slide. There are also questions about the vaccine allocation. And again, I think we sent these to everybody. You should have these. This is a pie chart which shows the distribution. As I mentioned, we're building the channels, so the hospitals have received 40% of the allocation, the local health departments 34%, CPS, Walgreens, which is the long-term care, Part A and Part B, 16%. So that's about 90% between those. Then we have the retail partners, which transfer program, which we've stood up, and that's about 3%. The FQHCs, which we want to grow that because they cover a lot of Medicaid throughout the state, and Kaiser Permanente, the same thing. They've got about 2%, and they've had very good performance so far. And then there's a smattering of others, about 4%. So this gives you an idea. The one thing I wanted to mention is that one of the things that's going to grow, and we've been talking to the federal government for several weeks now, when they get the Johnson & Johnson vaccine online, which should be coming, and you know, it's anybody's guess, but let's say March is a target. When we get to that point, they are going to open up what's called the retail pharmacy program. And what they have is a list, and we can get that information to you, of 22 national pharmacies, and they will then be sending allocations directly to the pharmacies based on requests from the pharmacy. That the state won't be involved in those allocations. So it is very likely, as this thing starts to take off, that you're going to see lots and lots of pharmacy doses coming from the federal government direct to the pharmacies. And we're trying to figure out how we're going to get visibility on that, probably through Immunet, but that's the back end of the process, not the front end. So there has been the system we use with the federal government is called Tiberius. That's their planning system. And they've said we would have visibility in Tiberius, but we haven't gotten there yet. So, but I just wanted to give everybody a heads up. 6-7 weeks from now, this whole calculation could be very different based on the retail pharmacy program. And then we have one last slide. You saw this last week, but I just wanted to continue to update you. You probably heard last week that we were going to get a 16% increase in first doses, and that did come through. So we had been at around 72. You can see we went 76 in the week of the 18th. We had a one-time bump on the 25th, and this past week our allocation was 88,000, and we've been told that we can count on 88,000 for the next 3 weeks. So that's helpful. But anyway, this gives you an idea. But you can see we've got 2,028,000 eligible. We estimate about 50% uptake would be 1 million who are eligible and seeking the vaccine, and we're now coming up around 700,000 available doses. And the supply, or the demand still exceeds the supply, but we're inching up over, and I expect over the next 3 or 4 weeks, we'll start to see some equilibrium there. And the last thing I'll mention is that you probably saw the governor's press conference on GoVax on Friday. That is an initiative that's directed at building confidence in our minority communities to get them to begin to raise our confidence in the vaccine. And we're going to be heavily investing in grassroots community-based outreach using mobile health units, sound trucks, and door-to-door canvassing. We're going to have heavy messaging. You probably saw that. We sent over a 2-minute video, but in the interest of time, we weren't going to play it. But you have it, that you can take a look at it. And people like Dr. Freeman Rabowski and Jacqueline Rabowski, the former Surgeon General, Delegate Pena Melnick, Bishop Walter Thomas in Gwynn Oaks, Reverend Matthew Watley in Silver Spring, and Dr. Kathleen Page, who's done great work with the Hispanic community at Johns Hopkins. So I'll stop there, Mr. President, and turn it back to you, sir.
Thank you very much. And I don't think we received the slides ahead of time. So next, we'll make sure that we check in ahead of time to add them in. I want to really focus in on this allocation question. So the minimum floor and the guidance that went out to health departments noted a 15,000 per week allocation broken into 3 tiers, the 300 doses for population of 0 to 99,000, the 700 for population between 100,000 to 200,000, and then 975 for the higher counties.
Yes, that's correct.
So, but it looked like there was 88,000 that came in, and at least if we're projecting 88,000 per week for the next 3 weeks, is that 15,000? Is that just for the health department to use?
That's just for the health departments, but the overall health department allocation is generally more than that. But there was a request from the health departments to give them a minimum floor so they can plan. But as we grow, we want to make sure that we give ourselves some flexibility. So we did give those floors going forward. But generally, if they need more, they're going to get a lot more than the floor.
So on that floor, I mean, I think that's my real question is, you have like a Harford County, which is somewhere around 250,000 compared to a Montgomery County, which is over 1 million. And their minimum dosages are the same, 975 for each. I just, that proportion doesn't compute well in my mind.
Yeah. Well, we can, we're always fine tuning this. We'll take that question back and look at it again. What the health departments were asking for is they just wanted to know that they can schedule off of that. But when we look at the actual allocations for the health departments, they're getting a lot more. But we're also using the health departments to target vulnerable and difficult to reach populations. So depending on the county, we ask them to give us their ask by Tuesday, because we're on this 9-day cycle, right, starting on Tuesday. So we wanted. Yeah, I'm sorry, sir. Go ahead.
So in that situation where there are, let's say, with 88,000, and you decide, let's call it 40,000 are going to go to the health departments, the delta between that floor and the 40,000, right? So the additional 25,000 doses, is that just the department that is sort of discretionarily hitting different targets? And the reason I bring it up is we've gotten some concerns that, teachers are obviously front and center. We want to get teachers vaccinated, get the kids back as soon as possible. Some counties have been getting a separate allotment for teachers. Other counties have not been getting separate allotments for teachers. It's above the floor, but is that just totally discretionary by the department?
Well, we're working with each county. I wouldn't say it's totally discretionary, but we're looking at each county to make sure that the cumulative for their county, whether it's hospitals, whether it's local health departments, whether it's pharmacies, because we're building the retail pharmacy capability. It depends on what their objectives are. We're gonna be urging, for example, counties to target independent living facilities, because there's 3 types of elderly living. We got the nursing homes, as you know, and then we had the assisted living facilities. But there are many facilities throughout the state, and we're working with Secretary Kramer from the Department of Aging on this. And we want to start identifying some of these facilities that aren't on a list for Part B, and begin to target those facilities with clinics working with the county. So, and if the counties were to say, well, that's not our priority, but it's our priority, we're going to want to make sure we drive, doses to those objectives. So it's a negotiation, quite frankly.
Okay. So I guess if you look, so the slide that we have up here on this one, this is the MDH's one. The Walmart, the retail provider, the retail partners are
Yes.
at first dose administration 50% and 36%. Obviously, they're ramping up production scales.
Right.
I heard that the Giant website crashed because of overwhelming use. If you go to the next slide, Jake, and look at the different categories of dosage, I mean, the local health departments for first dose are at 91.6% administration. They're sort of knocking it out of the park.
Yeah, they're doing great. We're really happy about that.
But they only have 15,000 doses per week as their floor.
Yeah, right. That's correct.
I guess is that a choice on the? It's hard to. I guess I'm trying to understand the prioritization and delivery method.
Well, let me start with the retail pharmacy question, because we had to front end load that for 2 weeks worth, which is why it was a little higher. And our data now, and there's always, it seems like for every category of vaccination providers, we end up having some data issues early on. Both the Giant and Walmart have used 100% of their doses, so we're trying to get those data problems synced up. And we had the same problem with Walmart or Walgreens and CVS, and with the hospitals and the nursing homes early on. But our data today, and we're trying to reconcile this, their numbers say that they've used 100% of what we've given them, both of them.
Well, let me make sure I give enough time. We're going to go.
If I could mention one other thing, if you look at Kaiser, if we could go to is that on the prior slide?
If you can go that one.
Yeah, if you look at Kaiser, they are heavily concentrated in Prince George's County and Montgomery. So we've been feeding them doses, and they're starting to hit it out of the park right out of the gate. So, and so we're really happy with that. So we're testing different channels. Some work better than others early on, but for example, Kaiser hit it out of the park right out of the gate.
Okay. We're going to go Senator Lamb, Senator Eckert, Senator Young, Senator Washington, and Senator Rosapep will clean up here. We're going to keep it at 5 minutes to make sure that we can get through everyone. So I'm going to hand it over to Senator Lamb.
Thank you, President Ferguson. My question has to do with these second doses. So since the very beginning of the vaccine program, the state has been adamant about not holding back allocations for second doses. That's been made very clear to hospitals and health systems. During a meeting of the Joint COVID-19 Legislative Workgroup on Wednesday, December 16th, which you attended, I had asked if hospitals and their frontline healthcare workers should be concerned about receiving the second dose when they needed one. Your department made very clear that they should administer all doses to not hold back. There was no concern. Today, I've heard that multiple hospitals and health systems are having difficulty getting second doses for their healthcare workers, that there are second doses that were supposed to have been delivered last week that are still missing and have not materialized. And now there are second doses for healthcare workers this week that are less than half of what hospitals are expecting. Can you confirm that this is a problem, that this is occurring?
That is correct. We think that in the transition between the two administrations, HHS has been having a struggle reconciling the data. So we're working with them. We've been on the phone with them all weekend trying to figure out. They haven't been able to put their finger on what the issue is, but they had an interesting turn of events last week where we had a 34,000 dose windfall, and then this week we suddenly have a 25,000. So I think in the transition process, they got a lot of new people trying to figure out how this data works. And but they're being very helpful, and our goal is to figure this out in the next few days.
Is there a plan currently to address this? Because I know it's causing a lot of angst amongst frontline healthcare workers who've been through a lot, obviously, and now are concerned that they're not able to get their second dose.
Causing a lot of angst with us, but we want to be, we're partners with the federal government, and we're putting a lot of pressure on them to figure this out. But it's causing us a lot of angst too. Now, the one good news about this is that if we figure, we're going to figure this out in the next few days. There is a 6-week period based on CDC guidance to get these shots in arms for the second doses. But we are working very closely with CDC, and our objective is to get the data right. They've got some problems.
Can hospitals that have also received doses for 1B and 1C then use some of that allocation to address their 1A needs, which are these frontline healthcare workers, if they don't have the second dose coming?
Are you talking specifically about second doses?
Right. Because they have some first doses that are of the same, right, the same Pfizer, Moderna, but right. Therefore people in 1B and 1C. We have now people in 1A that cannot get a second dose. Right. Can those be moved from 1B, 1C, dose 1 to actually ensure that those who need a second dose can get one?
Well, we'll take that under advisement. I don't want to give up yet on the federal government figuring out what's going on here, but once we get to the bottom of this in the next few days, we'll look at how to work the allocations.
Okay. Last week, you had also said that the state was continuing on with its current strategy, which was, as you responded to the president, was a decentralized approach. And then a few days after the work group meeting, the governor announced mass vaccination sites across the state. Can you be very clear about what the current state strategy is on how to best administer the vaccine? Because I think on one hand, we've heard about a decentralized approach. There are a lot of modalities that you explained earlier about how this is being distributed. And then yet there is also a centralized approach, it seems. Is it through these mass vaccination sites? And if so, what's going to happen to the people who are already registered through the local health departments or their hospital websites? The decentralized approach has led to a lot of our constituents going to a lot of different sources and shopping around to try to get their vaccine.
Right. Well, so, as I said last week, we're using a hybrid model. We're using some decentralized. We're going to be opening up other options like the mass vac sites. We want to have as many channels, and as I said last week, we're building this infrastructure so we can have as many channels as possible. So I wouldn't see that, thinking of it in terms of a hybrid model.
Okay. The last question has to do with the equity issue of distribution. So, I think some of these hospitals and health systems are actually allocating these vaccines or prioritizing them for their own patients, right? And so it raises a concern that if you're not a patient of Kaiser, for example, the one that you just used, or if you're not a patient of MedStar or a patient of somebody else, and therefore you can't actually tap into that allocation of vaccines for that health system, right? And then you also point out that on Sundays and Saturdays, there are far fewer vaccines being administered. That also means that people that have to work during the weekday may be set at a disadvantage to be able to get those vaccines on Saturdays and Sundays because there's fewer vaccines that are being administered those days. And so I think all of these are leading to potential equity issues. I'd like to hear how you're addressing them.
So you raise a good point, and that's exactly why we're doing the mass vac sites, because they will all be open on the weekend, so we can drive up our weekend numbers. So that's exactly correct. So as one of the missions of these mass vac sites is to make sure we have weekend access and we drive that up. So that's one issue. Your second question was what, Senator? I was focused.
I think there was only that one question, which is the equity issue. that, you know, if health systems are only limiting their allotment to people who have been patients of their health system, or it's only provided on Saturdays and Sundays, you lead to health equity issues there that only certain populations are able to access that. I think you already answered it, but the point being also, which was something I stated earlier, if you have these max vaccination sites, how are they being coordinated with the local health departments, right? The people have already registered in local health departments. They've also gone to their hospitals and health systems to register there, and then all of a sudden there are these mass vaccination sites. Do they have to register at another location too, or you know, our constituents are getting a lot of conflicting information there.
Right. So let me go back to part of the first question I didn't answer. With Kaiser, the reason Kaiser is so attractive is they have 490,000 members, of which 36% are African American, and 11% or more are Hispanic.
Right,
So
but it's not the general population, right? They're only administering to their own patients.
Oh.
Well, then in addition to that, they are going to provide us support at Six Flags, and that's where we're going to be handling these max vac sites. So they're clinical partners, and they're going to be doing both.
So we've got to move on. I want to make sure we have time. Senator Eckert, go ahead. And
thank you very much. Thank you, Mr. Assistant Provisional Secretary. I just want to be clear because I'm still not totally clear. Of the 88,000 doses that Maryland receives every day, is that 88,000 to the health departments? And then there's another allotment that goes to Walgreens and to CVS, and then another allotment to the other retail pharmacies, or is that 88,000 all inclusive?
So for now, the 88,000 is all inclusive, and that's gone up 16%. But as I said earlier, I expect when the Johnson & Johnson vaccine is approved, and we may see that as early as March, the federal government is already, and we were on conference calls with them last week, they are already planning to ramp up heavily with with retail pharmacies across the state, and they'll be giving those doses directly to the retail pharmacies. So what we're trying to do is get those things ramped up to make sure they work in the local jurisdictions, because we don't want to have the same thing as what we did with CVS and Walgreens, where they were unbelievably slow getting ramped up, and we've had to push them. So we're starting early on that process. But 88,000 is the total.
Okay, so if there are 496 doses coming down at 556 coming to Talbot County, that includes health departments, that includes Walgreens and CVS, who may not have completed vaccinating all of their healthcare facilities, and that will include then the Giant and the Walmart. So that would be the reason why the health department doses have decreased, correct?
Yes, that's correct. That is correct.
Okay, thank you very much. I just
thank you, Senator.
I'm concerned about the second doses as well, if that's what's happening, because people were probably anticipating holding or covering the second doses, and now it's kind of up for grabs. Thank you.
Thank you, Senator. Next is Senator Young.
Yeah, sorry, I had a link and I couldn't get in until just now. A lot of what I have has already been brought up in one form or another, but I'm a little confused. I mean, we're going to open a mass sites when all the other places aren't getting enough vaccines. What is to be gained by that? Just to give priority to the people that live near the mass sites?
The mass sites will be regional. The first two, as we said, are in Baltimore City and Prince George's County. We're going to have one in Western Maryland, on the Eastern Shore, in Southern Maryland. Those site selections are ongoing as we speak. So there'll be more coming on those as they are determined where, the details of those sites.
Well, based on the past, if it's in Western Maryland, you're going to put it in Hagerstown. That always happens. What good does that do anybody in my county? I mean, we're still trying to get 75, 80-year-old people vaccinated. And now you're telling me they're on all these waiting lists and they've got to drive to Hagerstown. I don't understand when we have people here on lists waiting and we keep creating more sites. Then I guess
Well, as we said
I mean,
last week,
it doesn't sound organized to me at all.
yeah, actually, it's very organized and it's very methodical. We are building the infrastructure to anticipate the growth in doses, which is coming very soon. And we want to make sure all this infrastructure is ready to go. And there is more demand than supply in every jurisdiction.
Okay, and this may have already been brought up, but it's an old subject. I still have the complaints that somebody gets their supply on Tuesday, they have to thaw it out. They're almost Wednesday before they can give it, and Thursday you guys are checking to see if it's been given, and it's making the people look bad because they're saying they have it done by Saturday or Sunday, but you don't even give them a chance after they get it to use it before you're reporting it hadn't been used.
Well, as I said before, we're on a 6 to 9 day cycle. We don't actually change the denominator in the calculations until Wednesday. So they get notice on Thursday or Friday. The doses arrive on Tuesday and Wednesday, and then they have all week to use the doses. And we're measuring as we go, of course, yes. But so there is going to be variability in the percentages, but as more and more doses are given, the denominator gets much larger, so the numerator will grow at a smaller rate because the denominator is so large, and then the percentages will start to work themselves out.
Well, when I see Maryland's not doing well, I can't tell if it's not doing well or if it's not being reported well. And
Well,
I'd kind of like to know which it is.
So you raise an interesting point. The number one complaint of the governors is the lag in data coming out of CDC. The National Governors Association had a call this past week with the Biden team, and that is the number one concern. If you look at our data when it is reported, the number of doses administered, we're about 20th in the country.
Okay, last thing, and I'm taking my time up. When we say CVC and CVS and Walgreens, it's not getting out to the stores. It's just going to the corporate dealing with nursing homes. Is that correct?
That was the plan of the federal government, which there was some merit to it. Get it into the nursing homes first, and then follow up with assisted living. I don't think what they anticipated was it was going to be as slow, but they're starting to make good progress there. I know our Part A is at about 74%. We're not happy with the slow pace, but it is starting to get done. And we're working with other pharmacies for the transfer program to give more options.
Well, when the supply comes, are you going to actually get it out to the pharmacy as opposed to corporate?
Yeah, by the way, I should have mentioned this earlier because you raised a good point. This is a just-in-time supply chain. So these doses are not coming to the federal government or the state. Those are paper systems or, things, they're systematic numbers. The supply chain is actually just in time from the manufacturer to the provider. So so when we're giving you the numbers, they're numbers that we're tracking with the federal government that through our Immunet. But when we're looking at the actual supply chain distribution, it's just in time from the manufacturer. Both
Last quick comment. It would be great if the health departments knew what was going on within their county, but they don't.
Right.
They're getting it out, and then you take supply away from them and send it other places, and they don't know what's happening. And it makes it difficult for them to know what's going on.
We're going to move to Senator Washington.
Thank you, President, and thank you, colleagues, and thank you, Secretary Schrader. First, I was really happy to see the memo of January 31st, encouraging local aging to coordinate with the local agencies. So I just have three questions. The first one has to do with that directive of saying that each local agency on aging is directed to work with. Right? What actually does that mean? And how is this coordination happening? Then you're sending a directive to the local health departments to coordinate with the local agency, and then you've given them an assignment of doing a number of things. Mm-hmm. So my question one is, who in your office is coordinating that? What technical support or advice or support are you providing to make sure that those connections are happening? So I guess that's my first question. One, can you explain those two directives, how they work together?
Yeah, thank you, Senator. We have a team of people working under Dr. Chan and myself, who manage all these processes, and they are working with the Department of Aging with Secretary Kramer. And what we want to do next is identify week over week, at least, and we were looking at high intensity housing situations for 75 plus and then 65 plus. And then what we will do is go to each local health department and say, look, here's a list, and we're going to pick one a week. We're going to say, here's one in your area. We'd like you to target this. And then the local health department will decide, do they want to do it or they don't. If they don't, then we will go through either a hospital or possibly a pharmacy. It really depends on the local jurisdiction's desires, but we are going to start targeting, because there's a lot of seniors that live in settings where there are large clusters of seniors, but they're not nursing homes or assisted living. They're truly living independently.
So I guess I was just I was sort of confused. I guess I want to say, what's your goal here? Because again, it's a lot. It's a very broad. I guess we're getting back to, and my colleagues have said this, that there's a lot of discretion. There's a lot of options. There's just a lot of that, and some would say might add to the confusion of an already challenging situation. So you've sent these two directives, one to the local aging agency, and then to the local, and then not quite sure what you're trying to achieve with that directive.
So let me see if I can try it again. We're working with Secretary Kramer. She knows where the aging population is clustered based on all the experience they have and all the data they have. There are many seniors who are in cluster housing who don't have necessarily, they're not part of the Part A program or the Part B program. And we just want to create transparency on where these populations are, and then work with the local agencies on aging and the health departments to target clinics in those facilities so we can get vaccines faster into that community.
Okay. And then I guess my other question has to do with your visuals. And again, thank you for that. And you were laying out the populations of the different counties and the percent of the population. And then I noticed that there are two counties, Montgomery County and Prince George's County, where at least 1.5 points, there's a difference in between the amount of its allocation and its proportion of the population. Can you?
Right.
So
Right.
those two counties are getting less than, you know, even using your own model, they're getting less than what we should get.
Yeah, we're pushing to, the reason we're using this data and we're making a transfer, we are pushing more doses into those counties through various channels to get those numbers to balance. So when you look at, well, for example, Montgomery County is like 11,297. Those are very large numbers, but we are making sure that also the doses per thousand and the percentage share are balanced too. So we're going to be looking at those carefully,
right?
Because we're concerned about the same thing that you just mentioned. We want to make sure those are equitable.
So wait, just so to be clear, and again, thank you for the time, colleagues. So to be clear, next week when we see those numbers, those jurisdictions that are getting a smaller proportion than the population, you're going to be targeting over the next week to make sure that the percent is at least that.
That's our objective, and that's what we do every week, and to make sure that these numbers are as close as possible.
And then finally, just in terms of making sure we're using the right metrics, I'd be interested, if you don't mind, if you could also add perhaps another column that might say the proportion of cases, COVID cases, and line those up. Because again, equity isn't just about making sure that you're dividing evenly or dividing based on population. Equity, from a public health perspective and any number of perspectives, is making sure that you're giving what is needed. So a column, if you wouldn't mind adding, to say what proportion of overall positive cases and also deaths or hospitalizations. And we could start looking at those numbers and maybe using that to support the allocations.
Right. We're actually, I'm glad you mentioned that, because that's precisely what we're going to do with the equity task force that Brigadier General Burkhead will be leading. That's going to be stood up here as we speak, and that was part of the governor's announcement last Friday, because we want to examine those numbers also. So that should not be a problem. That's one of our objectives.
Great. Thank you, President.
Senator Washer, we'll actually ask Mr. Powell to try to add that as well in that cross.
Thank you.
Senator Roosevelt.
Thank you very, very much. Can we put back up on the screen the numbers for Mr. Powell's presentation about the percentage, the number of doses we've gotten and the number that have been administered? It was that yellow and or orange and blue chart.
Hold on 1 second.
Do you want to go ahead and start
Why are you putting it up? What that shows, very dramatic, this is the chart, exactly. It shows an enormous number of doses we've gotten that have not been administered. I've been concerned for weeks that hospital systems and health departments and others were hoarding doses for exactly the reason that Senator Lamb raised, to save them for second doses. My understanding was that this health department was telling them to do that. I saw today that the Biden administration's COVID folks very specifically said publicly what I thought they were saying privately, which was do not hoard them, use them, we'll give you a predictable supply so you'll be able to do second doses. So my question is this chart just wrong? And they really don't have all those extra doses that we haven't administered? A, B, if it's not wrong, are you urging folks to use the doses they have or urging them to hold them back?
Well, we are very concerned about, because there's a timing difference, there's a float, and we've got a very complex chart. We can show it next week or we can send it to you, that looks at the second dose analysis, but there's about a 2-week float in here, which is different than the first doses. The second doses, because you've got the 3 and 4 week period to wait, causes a float. And what we're very concerned about, like we had this problem right now with NIH. We gave them extra doses for, or doses so that they could vaccinate and because they had people on the front lines. And then they went ahead and used all the second doses as first doses, and then ran out and called us and said, "Hey, we need another 5,000 doses." So we're trying to be very disciplined about this to make sure. And as you can see, actually, the orange line is growing and the blue line is shrinking. There will come a point when that will get very close. But in the early days here, they are ramping up.
So my question is, do you agree with the Biden administration's policy of not hoarding the doses, or do you support?
I don't think it's hoarding, because these are the supply chain is done through direct from the manufacturer. So
Well, I understand. Well, with all due respect, I have been told by local health departments and I've been told by hospital systems that they've gotten the doses and they've held on to them to do the second doses. So it's not, and that they've been told that you told them to do it.
That is true, absolutely, because we don't want to take any risk that an individual, just like somebody was raising earlier about the federal government having problems with this week's supply chain for second doses. We don't want to exacerbate that problem from the federal government.
Okay, well, I appreciate.
We want to make absolutely sure that if somebody gets a first dose, that they're going to get a second dose, because it's a complicated logistics problem to make sure that the individual that you vaccinated, you have the dose, you call them, you make sure you schedule the appointment.
No, and I understand, with it, Mr. Secretary, that's a last mile issue. I get the complexity of that. That's not related to whether we're using the doses that we have. So I appreciate that. I don't want to overstay my time here. My second question is, and this relates to earlier questions, is the average person, are they supposed to sign up if you're in the 2 million people who are authorized to get a dose, you're a teacher, you're a firefighter, you're over 65 years old, you're whatever you are, you qualify. Should you be signing up every single place you can to try to get an appointment? Or is there some centralized way you go one place and it signs you up every place?
Well, I'd have to think about that question and discuss it with you after, or maybe deal with it next week. I got to think about that one.
I would appreciate that. I think all of my constituents want to know the answer to that question. I think that's true for
all right.
Constituents. So I think that would be extremely, extremely helpful. Last question is, and this is the first time I really understood it. You're saying the federal government is pursuing the big drugstore chains on a significant way to get to scale, which I totally applaud. My question is, in terms of the numbers, are they determining the number that are going to go through the pharmacy chains in a state, or are you determining the numbers that are go through the pharmacy chains in Maryland?
I have that question myself and haven't gotten an answer yet. My understanding of reading their materials and talking to them is they're going to make those determinations with the pharmacies, because the pharmacies will be making the allocation requests. So we're studying this. There's still a lot of work to do to make sure we understand it, and there could be changes with the new administration as they're evaluating that program. But the way I understand it, it's going to be a relationship direct between the national pharmacy partners and the federal government. The federal government will make the allocations directly to them.
Thank you. Thank you, Mr. President.
Thank you. And thank you very much, Mr. Secretary. I just want to ask one final question. And I think I was hoping I just want to make sure I'm clear, because it's the question I get all the time. And I just, in the world, so this week, 88,000 we're told is the state. I'm assuming that's 88,000 total doses, a combination of first and second. Is that true?
No, that's first doses.
First,
88,000 first doses, and that's what we're really focused on, because once you get the first dose, you're in the queue and you're likely to get the second. But when we quote data, we're normally quoting first dose.
So that 88,000, you take 15,000 off the top, give it distributed by those three tiers. I mean, just hypothetically.
Yes.
For the local health departments, minimum 15,000 is gone. That remainder, that delta that's left, who is deciding the percentage and allocation of where it's going, what channel it's going through, who the target is? I mean, is that you and your team, Dr. Chan, that make that call? And then when do the
Well-
providers know ahead of time that last week we got 3,000, now we're getting 6,000? Like, how does that discretionary period play out?
Yeah, so it starts on Tuesday. That's tomorrow. We'll be analyzing where we stand. We also take off the top the transfer program and the Part B program where it's warranted.
What are those
And then
numbers
we look-
roughly?
I'm sorry, I don't have those off the top of my head because, we'll get those. So you take those off the top, and then we have the leftover. Like last week when we started, we had 70,000, and then we distributed them to the pharmacy program. Next week we'll be distributing them also to the mass vax sites, and then from there we look at where are the hospitals, what are their objectives, things like I mentioned earlier, seniors. Are we penetrating the seniors? There's another population around developmental disabilities. We want to start targeting that community, and so we're managing that using a lot of different factors. And then, of course, the other thing we're going to start doing as we ramp up our VOW program, we're going to be targeting other communities. So, for example, we'll look county by county. Prince George's County will say, okay, wait a minute, our numbers aren't where they need to be. How do we get these numbers up, and which channels can we use to get those numbers up?
And that's
So
your
it's
team on Tuesday.
That's our team. We have a very robust team of people who evaluate that, look at the data, analyze it. And so Tuesday we do a preliminary. Wednesday we get more information. Thursday we propose a final, and then and then on Thursday we're doing a bulletin that advises. Like last week, you heard the governor announce we wanted to target people who are in hospital programs, both inpatient and outpatient, who had certain disease entities like cancer, transplant. So that's another targeted population. So we have to make sure we have doses allocated to that. So it's a very intensive data-driven analysis so that we keep moving this ball.
Great. Well, thank you. Well, I want to make sure we stay on time. I do want to elevate Senator Rosa Pep's question. That is the one question that all of us are getting 100 times over. Where do we go to sign up? Do we sign up at all of them? Do we sign up at one? Where should we go?
We'll work on that, Mr. President, and have a good answer for you next week. Thank you, sir.
Thank you. Thank you all. Stay safe, wear the mask, get the vaccine, and we'll see you all next